Kia ora koutou katoa. It's my pleasure to spend the next 15 or 20 minutes speaking to you about breast cancer and pregnancy, specifically breast cancer before pregnancy. I hope that at the end of my discussion you'll understand that this is a controversial topic, but you'll also have some understanding about where our current knowledge on this important issue is. I have no financial conflicts, but I do need to disclose that I'm not a fertility specialist. I also need to disclose that I'm a medical oncologist, so I will have graphs and I will have tables. Sometimes it's a bit confusing, and if it's not making sense, close your eyes and just listen, because it's all in the words as well. Okay. Why is this important? For most of you in the room, the answer is really obvious. Breast cancer and pregnancy are important. Pregnancy after breast cancer is particularly important because many women with a diagnosis of breast cancer haven't completed their families yet. Additionally, it's relevant because there are a number of controversial areas to discuss, and there has been a paucity of consistent advice on this issue. Pregnancy after any cancer is difficult. This graph here is one of those forest plots that Pamela was showing earlier, and the dotted vertical line in the middle represents the general population. If you look to the left of that, you can see that for any female cancer survivor, the chance of pregnancy is reduced. But I'll draw your attention to the horizontal line for breast cancer at the bottom of the graph. This shows us that breast cancer survivors have the lowest chance of subsequently becoming pregnant. You'll also all be aware that breast cancer incidence increases with age, and it's largely considered a disease of postmenopausal women. Our own New Zealand statistics show us that around 10% of breast cancer cases are reported in women aged less than 45 years. So for 2013, the preliminary numbers show 344 cases of breast cancer reported in women less than 45 years. But this number's probably increasing since we've observed an increase in the incidence of breast cancer in New Zealand over the last decade. Internationally, we see an increasing age of first pregnancy, and in New Zealand we're no different. The median age of first pregnancy in our country is 28. That means that half of all women becoming mothers for the first time are aged over 28. So I think that in view of these local and international statistics, it's clear that pregnancy after breast cancer is perhaps more important now than it has been in the past, and will probably become more important for a larger number of women in the future. So I think my assumption is supported by some research predominantly done in the USA, where they've surveyed a large number of young women with breast cancer. This particular publication surveyed 600 women aged less than 40 at the time of their cancer diagnosis, and around half of them acknowledged that they were concerned about fertility. This publication also showed that 2/3 of women had the opportunity to discuss fertility with their oncologist. That should have been 100%. So how is fertility affected by a breast cancer diagnosis? For premenopausal women with breast cancer, oncological treatments can impair fertility either by a direct toxic effect on the ovaries, for example with chemotherapy, or by delays to conception. So we know that 5 years of tamoxifen, perhaps longer, is frequently encouraged, and this can allow natural ovarian aging and so close the fertile window for a woman with breast cancer. Most young women with a breast cancer diagnosis receive both chemotherapy and endocrine therapy, so there's a double hit on their potential fertility. Chemotherapy can induce amenorrhea. When I say amenorrhea, I'm talking about the cessation of normal menstruation. This can be permanent or temporary, and the likelihood is related to both the drugs that are received, the age of the woman when she receives them, and how many cycles of chemotherapy she has. But the bottom line is that for approximately 1/3 of women under 40 receiving current standard chemotherapy regimens, there will be a loss of normal menstruation. Chemotherapy damages the small blood vessels within the ovary, and chemotherapy can also lead to death of the primordial follicles. Primordial follicles are immature eggs. You've born with them, you have your complete load at birth, and then over time they're used up. So these two insults to the ovary are occurring even in women who continue to menstruate throughout chemotherapy. And each course of chemotherapy results in a further loss of the total number of those primordial follicles. As I said, that number reduces with age, but because younger women have a larger reserve of follicles, they've got a larger buffer to tolerate those losses, and so they might not experience ovarian failure in the short term after chemotherapy. But even those who continue to menstruate through chemotherapy or resume menstruation after chemotherapy, they do experience an earlier menopause and thus an earlier loss of potential fertility. So we've established that pregnancy may be desirable after breast cancer, but that treatment for breast cancer can impair fertility. The first controversial issue is the safety of pregnancy after breast cancer, and it has been an area of concern. An Italian survey of oncologists showed that up to 40% of oncologists believed that the hormonal changes within pregnancy, particularly within 2 years of a breast cancer diagnosis, might increase the risk of a breast cancer recurrence. And it's pretty shocking to me that this statistic is not many years old, but was just published last year. So how can we ascertain the safety of pregnancy following a breast cancer diagnosis? We're never going to have a high level of robust evidence around this. You can't randomise or allocate pregnancy to a woman. So we have to rely on different methods of understanding the risk here, which means relying on case series or data that's drawn from large breast cancer registers. And in 2013, a very important publication was made available. This was a multi-centre study. It was retrospective. It was drawn from databases around Europe. They undertook the important task of exploring the safety of subsequent breast cancer, particularly with respect to the hormonal status of the cancer. There was data from 333 women who had become pregnant, and they were matched to breast cancer survivors who had not become pregnant. So they were matched in terms of age, tumour characteristics, the type of treatment, and the year of diagnosis. There was no difference in survival between these two groups. What those graphs are showing you, and you may have to take my word for it, but the blue and the yellow line on those graphs are sufficiently close to tell us that whether you became pregnant or did not after a breast cancer diagnosis did not impact on your prognosis. And in my opinion, these results underscore the safety of pregnancy following breast cancer. So I think that puts the first controversy at rest. If that's the case, how do we preserve fertility? How do we facilitate pregnancy for women who've had a breast cancer diagnosis at a young age? There will be some of you who are familiar with a drug called Zoladex or Goserelin. This is a man-made formulation of a hormone which is naturally produced in your brain. What happens with a normal menstrual cycle is that you have a pulsatile release of GnRH, also known as LHRH, and the pulsatile release is important for precipitating a normal menstrual cycle. But when you administer this chemical at a steady level, it tricks your body into shutting down the production of its own hormones. So it interrupts a feedback loop, and it means that ovulation doesn't occur. So the theory was that if you administered this drug concurrently with a course of chemotherapy, the woman wouldn't ovulate, and you'd protect the ovaries from some of the damage that chemotherapy can cause. Unfortunately, the early trials exploring this approach provided inconsistent results, and so the jury was out until a couple of years ago when two large studies, the PROMISE and the POEMS study, reported. There may even be people here who contributed to the POEMS study because we were quite high recruiters in Auckland. What these studies showed that, yes, if you gave the injection, it's a monthly injection, if you gave that concurrent with chemotherapy, then ovaries were somewhat protected and there were reduced rates of amenorrhea. There was a 50% reduction, resulting in less than 10% ovarian failure in women who received the injection alongside their chemotherapy. So we have confidence now that using Zoladex or other drugs in that family can reduce the chance of premature ovarian failure. But does it result in more pregnancies? Because it's not the same thing to be having a period and to be fertile. Pooling the results of the 5 main studies, this is another one of those forest plots or box and whisker plots. Here on your right-hand side, the squares favour the administration of the LHRH agonist, and this set of results demonstrate that concurrent use of Zoladex with chemotherapy did result in more pregnancies, but there's a big caveat here. The numbers are really small. So in the treatment arm, there were only 33 pregnancies out of more than 350 patients, and in the control arm, just 19 pregnancies. So I'd suggest that this is encouraging for the preservation of fertility, but the numbers are really too small to put our hand on our heart and say this is a way to make sure your fertility is maintained. But it's a really good start. Okay. How else can we preserve fertility then? Assisted reproduction. This has also been a controversial area. Now, when I say assisted reproduction, I'm talking about stimulating the ovaries, retrieving the eggs, and then either freezing them or inseminating them and freezing the embryo. And both of these techniques are available in Auckland. Assisted reproduction can be considered as a means to preserve fertility prior to treatment, but it does need to be done prior to treatment in order to reduce the destruction of the oocytes in the ovary. The controversy here is that it can lead to a delay in the initiation of chemotherapy. The other part of the controversy around assisted reproduction is that ovarian stimulation results in very high levels of estrogen. So can we mitigate some of these concerns? Typically, a schedule for ovarian stimulation is performed at the beginning of a menstrual cycle, and that can mean up to a 3-week delay while you wait for a woman to get to the right point in her menstrual cycle to then do the ovarian stimulation. And we have a concern about delaying chemotherapy. We know the time in between chemotherapy and surgery is an important variable when you're estimating prognosis. But in recent times, a new schedule of ovarian stimulation has been tested. It's called a random start protocol. It means that ovarian stimulation can begin at any time during the menstrual cycle. And there are an equivalent number of eggs retrieved doing this random start approach. It does require a few more days of stimulation, but it's considered a very reasonable emergency fertility preservation intervention. And we encourage this because we think it can mitigate that delay to chemotherapy for women who want to explore a fertility preservation intervention. The other concern with assisted reproduction is the high estrogen levels. So as I said, ovarian stimulation is associated with a very high rise in estrogen, almost 3 or 4 times that what you might encounter naturally. And as you'll all be aware, the effect of estradiols in promoting hormone receptor positive cancer is precisely what our endocrine therapies are designed to overcome. So it follows that there has been concern about the impact of these high estrogen levels in a fertility maneuver. There are some studies now which have looked at ways to mitigate the rise in estrogen, and the most popular approach is to add letrozole because of letrozole's effect in reducing total estrogen levels. It can almost take those estradiol levels down to about a third. And the success in terms of live births following ovarian stimulation from this approach is also equivalent to the live birth rate for IVF in non-breast cancer patients. Right. The final question about assisted reproduction is really, is it safe? This is the best data we have at this point. This is a study where 217 women were offered fertility interventions prior to their cancer treatment. Eventually, just 79 went forward for ovarian stimulation, and 81% were ER positive, which is about what you'd expect. At 2 years of follow-up, there was no difference between those who had undergone ovarian stimulation and those who hadn't. And at 5 years, there persists, there's still no difference at 5 years. So based on the information we have, yes, it's safe. This 5-year update is only from this year, and as we know, hormone receptor positive cancers can relapse late, so there does need to be an acknowledgement that this data is probably immature for ER positive cancers, but it's enough for me that I would encourage women to pursue fertility intervention before I commenced them on chemotherapy if they hadn't completed their family yet. And in Auckland, we do have 2 services available, Fertility Plus and Fertility Associates. The treatment or the intervention that they offer for breast cancer, for women with breast cancer, is funded, provided that the standard criteria are met. So it's age less than 40, not postmenopausal, for obvious reasons, and not more than 1 child, and BMI less than 30. They are very good at seeing patients in a timely fashion, so they will usually acknowledge and make an appointment within a week. And the minimum amount of time to commence ovarian stimulation is 2 weeks. That means that for some people it is going to be longer. So there may be some delays to chemotherapy here, but much longer than there was in the past. I have previously been asked, why is there a BMI criteria here? What's weight got to do with it? Actually, it has a lot, because maternal and child outcomes for pregnancies in obese mothers, and obeses greater than 30, have much poorer outcomes. I have also been told that for women with a history of breast cancer, there may be some flex, so we wouldn't not make a referral just because the BMI was greater than 33, but that's where that number comes from. Right. This is a bit of a hot topic at the moment, and I consider this to be the final controversy. The feasibility of becoming pregnant after 5 to 10 years of endocrine therapy is a major challenge. This raises the question of whether temporarily interrupting someone's tamoxifen to facilitate a pregnancy is a safe approach. And in the real world, on a case-by-case basis, such an approach is taken, but it's not without a degree of anxiety. We make the decision more comfortably in women who have a low baseline risk, or women who have already completed, for example, over half of their endocrine therapy, or women who are really at the outer limit of their fertile window. What we have to confess is that we just do not know whether such an approach is detrimental. It hasn't been addressed in any studies. There is one very ambitious, large international study underway called the Positive Trial. It's not a study of allocation or intervention. As we've said, you can't randomise someone to pregnancy or not, but rather what they're trying to do is systematically approach and collect the information on endocrine therapy interruption, so that over time we'll have a better understanding about the impact of this approach. They've chosen to recruit women who have already completed 18 to 30 months of endocrine therapy. Why have they chosen this number? Partly it's based on a survey of young women with breast cancer who over half of whom indicated they would contemplate a pause in treatment provided they had already had half of their treatment. And partly this number also reflects some historical data where we know that at least 2 years of tamoxifen is quite effective. Right. They're going to follow women up for 14 years after their pregnancy, and this study only started recruiting in December 2014, so unfortunately we are a long way away from any hard evidence around the safety of this approach. For women who do achieve a pregnancy after a breast cancer diagnosis, there will be questions around breastfeeding. So first of all, to say that we advise women undergoing cancer treatment not to breastfeed. Some of our cytotoxic drugs are excreted in breast milk, and we don't know a lot about the excretion of endocrine agents. For women who fall pregnant further down the track from their diagnosis and treatment, there's very little evidence to guide the approach here, but anecdotally, the milk from a previously irradiated breast probably comes at a slow flow, low volume, and an altered appearance. So the common approach is to feed off the unaffected side, and there's no reason, no cancer-related or treatment-related reason why milk production on the unaffected breast should be impeded. So in summary, given the rising trend of delaying pregnancy until later in life and the successful use of adjuvant therapies, I predict that more women will be diagnosed with breast cancer before completing their families. We can offer the LHRH or the Zoladex type drugs to reduce amenorrhea, and we hope that they will help preserve fertility, but that hasn't been established with certainty. Pregnancy following breast cancer is safe and it shouldn't be discouraged. We also think that ovarian stimulation for the retrieval of eggs and IVF is safe, but time will give more information in that area. And similarly, the safety of interrupting endocrine therapy is not completely known, and an individualised approach is encouraged. Thank you.
Thank you. You mentioned interrupting tamoxifen for pregnancy, that may be possible perhaps halfway, once you've already completed half. Is that half based on 5 years or 10 years?
Based on 5 years.
Thank you.
Any other questions?
That's one. Oh, there's one there.
Hi there, I was just wondering what the downtime is after you've finished your Herceptin treatment. How long should you wait after finishing Herceptin to try and fall pregnant?
That's a really good question. We commonly advise women wait 1 to 2 years after they finish their cancer treatment before attempting a pregnancy. That is not evidence-based. There's no data to advise on that. It's trickier if you've been on a treatment which lasted a whole year or more, for example, Herceptin. Part of our 1 to 2 year yardstick is around the higher risk of recurrence in the first few years for particularly aggressive cancers. Part of it is based on recovery of your own physical health to sustain in an enjoyable way a pregnancy, but that is not evidence-based. And so if you're someone who's completed your Herceptin, the drugs are out of your system, they're long gone. It's really about, have you had enough time to regain your physical health, and are you someone who is at such high risk of relapse that you might want to buy a bit of time and just see what the future holds first, because as you will have heard, for some cancers there are high relapse rates in the first 2 to 3 years, and we're mindful of that. Okay.
Oh, just one final question here.
Just a quick questions. After stopping tamoxifen to try to get pregnant, how long it's safe to go back to complete the second half?
Yeah, so again, my current advice on this is based on the schema that they're using in this trial, because some very clever people spent many years designing this trial, and what they have suggested is a 3-month washout period. That's based on how long the tamoxifen takes to degrade in the body. So if you're trying for a pregnancy, it should be off tamoxifen for at least 3 months, and then they are happy to resume resume tamoxifen as soon as breastfeeding is finished. Have I answered your question?
If it takes 2 years to get pregnant, though, how long is it safe to go without being back on the
We don't know. In the study, they're allowing an interruption of 2 years. So they're not, women who are unable to achieve a pregnancy and return to tamoxifen within a 2-year time period are considered outside of their acceptable parameters. So that, again, is what I would be guided by at the moment.
Thank you very much.
One small one. My sister was breastfeeding when she diagnosed with breast cancer, and she was breastfeeding while she's taking the chemotherapy. So, what happened to that child?
Hopefully, that child is absolutely fine.